So today we are going to look into the musculoskeletal masterclass for NPTE exam. This is the only video you want to watch if you really want to clear the NPTE in first attempt. If you are skilled in musculoskeletal and you can able to get the musculoskeletal part all correct, that's about 60 to 70% of the exam, right? So the chances of you getting your ability to clear this NPT on the first trial will be much higher if you're able to get this stuff done. So musculoskeletal is one thing that high yield questions are coming from this part. So you need to know the musculoskeletal as considered as the holy grail of NPTE mastery. So that's why we are giving away this completely free for you. This is a probably 1 hour class, and by the end of this class you will be mastered in different joints and the questions related to that and how to answer that for your NPTE masterclass. So NPTE Strike, I started this with the vision of helping students who were going through the same struggles as I went through. It was really hard for me to clear this exam as I was an international trained PT. Coming here and clearing this exam was one of the biggest challenge I had in my life, and I wanted to make sure anyone who else coming from different part of the world, or if you're in US and trying to clear this NPTE exam and you couldn't, this might be the video that is going to help you clear this. So I want you to stay till the end of the class, get maximum content from this, and that will help you to clear this exam, right? So one exam, one answer, one question, one answer, right? That's NPTE Strike got. And the one answer, one question, one exam, and there's only one course that is going to really help you, and that is this NPTE Strike that I created, right? So we are going through shorter complex today. It's not everything. It's just think about that. This is a completely free masterclass. We have a 3 bundle course in our website. Is going to be going deeper to each and every pathologies that you need to focus on to get this done, right? Here we are focusing on very high yield questions that you need to focus on for NPTE, right? So we are looking at the shoulder complex today: elbow, wrist and hand, cervical spine, thoracic and lumbar spine, hip and pelvics, knee and ankle and foot also. Let's see. So the part 1 is a shoulder complex. Rotator cuff pathology. Rotator cuff consists of supraspinatus, infraspinatus, teres minor and subscapularis. So that's called SITS, right? Supraspinatus, infraspinatus, teres minor and subscapularis. So these muscles provide dynamic stability and coordinate glenohumeral motion. Rotator cuff pathology exists on continuum from tendinopathy to partial thickness tear to full thickness tears. So when you think about rotator cuff pathology, this is a very high impact area which you should be looking into. There can be different conditions in this shoulder pathology. There can be tendinitis, there can be labral tears, there can be rotator cuff tears. So you need to see what condition they have, what is the sign and symptoms, what is the pathology, right? And to see the case of the question and to answer it, right? So key features, you have something called painful arc. So there's different arc, so 60 to 160 to 120 degree with abduction, particularly with the supraspinatus involvement. If someone has a supraspinatus involvement, there can be a painful arc. Now weakness in external rotation, infraspinatus, teres minor, or internal rotation, subscapularis can also be seen, right? Positive impingement triggers like Neers and Hawkins-Kennedy. Positive MT can test for supraspinatus pathology, and drop arm signs suggest a full thickness tear. So usually what happens is, especially in the clinics, you're going to see these patients that come to you very regularly. So usually when supraspinatus is involved, that the pain will be from 60 to 120 degree of abduction, they will have pain. Right now, if you see there's a weakness on external rotation, that is indicating an infraspinatus and teres minor issue, or internal rotation subscapularis issue. Now, positive impingement signs include Nears and Hawkin-Kennedy. That's a very common test that you can do to see the impingement, right? And there's positive MTK test. So this is what you can use to see the MTK. So MTK is going below. That is usually indicating supraspinatus. If you go up, that can be infraspinatus. Drop arm test is that you're keeping your hands like that and then you drop it. Patient won't be able to hold because the rotator cuff is completely teared. So these are certain things you want to keep in mind before we go into the question. So NPT key concept: distinguish between tendinopathy and full thickness tears. So you need to know that you need to see the difference between a tendinopathy issue and a full thickness tears. So usually what happens with the full thickness tears, surgical referral is needed for their management, right? With the tendinopathy, you need to get better. You need to start eccentric loading and progressive resistance. That's what you need to do to get that one better. You need to know how to eccentric load the tendons and then progressive resistance. So fatty infiltration and tear retraction are poor prognostic indicators. So if you see that there's a fatty infiltration in a tear and there is a tear retraction, then that means there's a poor prognostic indicator usually. So this can be coming in your questions also, so you need to keep that in mind. Now, evidence-based management in a very acute state, if there's a pain, a lot of pain and inflammation, the goal should be pain control and gentle passive range of motion. Then you're looking into the scapular stabilization exercise, activity modification, right? And on subacute phase from 2 to 6 weeks, our goal is to progressive range of motion, active range of motion, scapular motor control, rotator cuff strengthening, pain-free. So the mainstay of these things are that scapular stabilization and postural control is what the cornerstone of these things. Other things are important, but once the pain comes down, you need to start working on scapular stabilization and postural corrections, right? Chronic pain more than 6 weeks, progressive resistance, eccentric loading, functional training, return to activity. There's a chronic phase of management that become more aggressive, and you're getting a lot of the eccentric loading and you're loading the tendon basically, right? Now, failed conservative management with structural pathology, usually we need to refer them for a surgical consultation. Sometimes the physical therapy conservative management can fail, and if you feel that it's failed, it's not working, then you probably need to refer them for a surgical consultation. Now, clinical pulse. Scapular dyskinesia is present in 67 to 100% of patients with rotator cuff pathology. Always assess and address scapulothoracic rhythm and periscapular muscle strength. So if you see a patient who is coming with not just a rotator cuff injury, right? If you have a labrum issue, any kind of injury on the scapula, then there's a shift in the rhythm of the scapula. Now what happens is, this is called scapular dyskinesia, and it usually come around 67 to 100% of the patient population with rotator cuff. So you need to make sure the scapular thoracic rhythm and periscapular muscle strength is addressed earlier. So what happens is they usually see that elevation of the scapula, right? So you need to prevent these things. You need to strengthen a stabilization of scapula is very important. That's why periscapular strengthening become a really important thing in this case. So now with that idea, let's go to a practice question. A 58-year-old office worker present with right shoulder pain, 7 of 10 for 4 months. The clinical finding, you can see the Hawkin-Kennedy test, painful arc of 60 to 120 degree, and weak 3+5 and painful external rotation. Full passive range of vision, all pains. MRI reveal partial thickness of supraspinatus tear, less than 50% thickness with no fatty infiltration. Patient report difficulty reaching overhead behind back. Conservative management includes 6 weeks of PT, scapular stabilization and progressive resistance, has shown minimal improvement in pain or function. What is the most appropriate recommendation? So sorry about that. So one of the common thing that you usually see with the supraspinatus tear is that there are pain on the Hawking-Kennedy test, painful arc is there, and painful external rotation. So external rotation is a function of the supraspinatus, right? So that's the one thing. And the thing is, we did 6 week of PT program, and there is minimal improvement in pain or function. So what is the most appropriate function you will be able to do next? Now if you see that, refer to surgical consultation for rotator cuff repair, continue progressive resistance training emphasizing eccentric loading of the rotator cuff. Recommend trial of corticosteroid injection followed by another 6 of modified PT. Discontinue PT and advise work modification with the permanent activity restriction. What is going to be the best answer in this one? Right, so the correct answer is C. Recommend trial of corticosteroid injection followed by 6. Oh sorry, let me put that black and add that 6 week of modified PT. Now why does it that matter? So NPT is also all about decision making. It's not about memorizing anything, right? So this is a classic NPT decision point, testing your understanding of the conservative management continue for the rotator cuff pathology. So step 1, you analyze the data. Partial thickness tear less than 50%, right? So it's less than 50%. No fatty infiltration. Usually surgery become necessary if there's a fatty infiltration and the retraction of the muscles are there, right? So here no fatty infiltration, 6 week of PT with minimal improvement. So there is some improvement, minimal improvement, persistent function, pain and functional deficits, right? Step 2, you're eliminating the obvious answer. So this you don't want to anything, right? Your activity restriction, permanent restriction, you don't want that. We have an exhausted conservative option. And then you're going to do the apply big 3 to remaining options. So what do you mean by big 3? So if you're if you don't really know what technique we are using here, you need to go watch one of our videos of triple wire. There's a video, clinical decision making, that is something you should watch. Now how to get every answer right every single time, that's a video you should watch. So these are the videos that help you make clinical decision. You might have all the knowledge, right? You might have all the content in your head, but how to choose the right answer comes from the decision making. And that's what actually NPT is testing. NPT is not testing your memory, right? So apply big 3 to the remaining options. So option A, surgery. Surgical repair is typically reserved for full thickness tear, especially with the retraction or fatty infiltration. So that's one thing I want you to take home. Surgical repair with the shoulder cases is usually for full thickness tear, right? Not partial thickness tear, and there should be a fatty infiltration, then the healing become even harder, and then there's a retraction, right? So these are the places where we go for the surgical repair. This is a partial thickness tear with no fatty infiltration. Surgery is premature, too aggressive for the pathology. So surgery choice right now is a premature choice you are making right now. Option B, more PTs with eccentric loading. We already tried 6 weeks of progressive resistance, while eccentric loading is evidence based for tendinopathy. We have plateaued. Simply continuing the same approach won't change the outcome. Option C, corticosteroid injection can reduce inflammation and pain in partial thickness tears, creating a window for more effective therapeutic benefit compared with the modified PT approach. This represents a reasonable next step in conservative continuum before considering the surgery. This is the most appropriate one. So option B, why is not PT with eccentric loading? That's standard for these issues, but we already tried 6 weeks of progressive resistance training, which didn't work as we thought. So while eccentric loading is evidence-based for tendinopathy, we have plateaued. So sometimes in recovery, if you plateau, simply continuing the same thing, same approach won't change the outcome. You need to make changes on what you're doing. Option C, you need to do the injection plus modified PT. So corticosteroid injection can reduce inflammation and pain in partial thickness tears, creating a window for more effective therapeutic exercise. So in this case where you need to bring the inflammation down and make it faster, corticosteroid injection is something you should do. Combined with the modified PT approach, different exercise dosing or manual therapy. So these represent a reasonable next step to the conservative continuum before considering the surgery. This is the most appropriate thing we should do now. Now, the NPT expect you to know the stepwise progression. PT alone, then you're going for injection plus modified PT. Then if that is also failed, surgical consultation if conservative fail. For partial thickness without fatty infiltration, surgery is not the first line. So this is one thing you take home. This is going to be going to help you. So if you know this knowledge, it's going to help you with making decision. So when you come to a issue with the shoulder, you are always trying conservative PT first. If it's not working, you don't want to do the same thing of eccentric loading. You're giving them a corticosteroid injection, try to bring the inflammation down a little bit more, and then you're doing a modified PT. Then you are doing a surgical consultation if the conservation fails, right? For partial thickness tears without fatty infiltration, surgery is not the first line after failed PT. Now, clinical per injection plus PT is an intermediate step. Surgery is reserved for full thickness tear with the poor prognostic indicators or failed comprehensive conservative management. I want you to take this home and keep it in write it in your top of the head, keep it in your heart, right? Injection plus PT and is an intermediate step. Surgery is reserved for full thickness tear with the poor prognostic indicators or failed comprehensive. What is the poor prognosis? Fatty infiltration and retracted muscles. Now we're going for adhesive capsulitis, another high yield question, high yield content in the shoulder. Now, on adhesive capsulitis, frozen shoulder is characterized by a progressive loss of both active and passive glenohumeral. So this is the one thing you need to know: progressive loss of both active and passive glenohumeral range of motion with the capsular pattern restriction. External rotation more than abduction, more than internal rotation. It progresses through 3 stages. It goes to freezing, and then frozen and thawing. 0 to 9 months is where you have the freezing stage. 9 and 4 to 12 months is usually where you see frozen stages, so they can be overlapping. And then thawing stage, 12 to 42 stages. So freezing, frozen and thawing. 0 to 9, 4 to 12, 12 to 42 months, right? So that's more than 1 year of recovery in this frozen shoulder. And there is a pattern called capsular pattern. Usually what happens is the most limited will be external rotation, and then the abduction, then the internal rotation. Through 3 things are restricted here: external rotation, abduction and internal rotation is the 3 things that is usually restricted in these patients. Now, how will you diagnose a patient with adhesive capsulitis? So if you see the insidious onset of shoulder pain, they usually say, I don't know how it started, it just started. Then usually that's one indicator of a diagnosis of adhesive capsulitis. Then there's a capsular pattern, which is external rotation most limited, then abduction, then internal rotation. Then you will see reduction in both passive and active range of motion, because as the capsule is becoming more thicker and jelly. So even if you try to go within passive, you won't be able to. Radiographs are normal, rule out other pathology, no history of trauma or surgery. Now, capsular pattern is external rotation, abduction, internal rotation, adhesive capsulitis and arthritis. Non-capsular pattern, isolated loss in one plane, usually says there's a labral tear, there's an impingement or a muscle guarding. This distinction is high yield for NPTE, right? So this is a very important thing you need to know. So external rotation, abduction, internal rotation, LPC capsulitis and arthritis. Okay. It's not just an LPC capsulitis. Sometimes arthritis can also give you this kind of pattern. Now, stage specific management is also important. Now, what do we mean by stage specific? There can be freezing, there can be frozen, and then there's thawing. What you usually see in freezing stage is that's increasing pain, decreasing range of motion. So freezing stage is where you start to get the pain. That will be the pain will be the highest at this place. So the goal should be is to bring down the pain control, gentle range of motion with the pain free patient education, and avoiding aggressive stretching at this phase. And then frozen stage, it's called frozen because that's where the stiffness come in more than the pain. So progressive capsular mobilization grade 3 to 4, you can usually use contralateral stretching, manual therapy, heat before stretching. These things are need to be done at the frozen stage. And then there we have thawing. So here what happens is there's an aggressive stretching phase. Here our goal is to bring down the range of motion. He will get the range of motion back, so functional training, return to normal activities become more and more specific in this case, right? So overly aggressive stretching in a freezing state can increase inflammation and prolong the symptom. So you need to understand when there is an inflammation going on, you need to take it slow, you need to take it, calm down in the inflammation. So overly being aggressive in this early stages of frozen shoulder in the freezing stage can create a lot of inflammation, right? So match intervention intensity to the stage. Then this is something that NPT continuously tests you, right? You need to make sure your how aggressive you are with the treatment should match the stage of the healing of that patient. A 52-year-old woman with type 2 diabetes present with left shoulder pain stiffness for 3 months. She reported difficulty sleeping on the left side and cannot reach behind to fasten her bra. Examination revealed passive range of motion limited to 85-degree abduction, 20-degree external rotation at the side, and pain 6 out of 10 at end range. Empty and feel is all restricted plane. Strength testing referred due to pain and range of motion limitation. The patient's primary goal is to improve overhead reaching and sleeping comfort. What is the most appropriate initial PT intervention? I know you already saw the answer, but let's go back to the question. Try to understand it. Age is 52, woman with a type 2 diabetes. There's two different cases where the frozen shoulder, three cases where the frozen shoulder can come. One, you have a diabetes, uncontrolled sugar level, right? So diabetes is there, so inflammation is there, so you're getting a frozen shoulder. The other one is thyroid issues. If you have hyperthyroidism, there's a chances of frozen shoulder. The other one is you went through a fracture, you immobilized for shoulder for any reason for a long time. That can also trigger frozen shoulder, right? So here the patient has a type 2 diabetes, left shoulder pain, stiffness for 3 months, and difficulty with sleeping on left side, cannot reach by fasten her bra. Examination reveals passive range of motion is limited to 85-degree abduction, 20-degree external rotation at the side, right side 140 abduction, 70-degree external rotation. So the left side, significant limitation on external rotation abduction is happening, and pain is at 6 out of 10. So this is actually still on the early phases, right? 6 out of 10 at the end range. Empty and feel in all restricted planes. Strength testing deferred due to pain and range of motion limitation. Patient primary goal is to improve overhead reaching, sleeping comfort. So what is the most appropriate intervention? So since this is still on a very inflammatory stage, you need to go for B. Why is other things? These are aggressive restore range of motion, probably on the later stages like thawing or frozen stage. Progress resistance exercise rotator, that's also come. This is also comes on the later stages. So thing that we really need to know is what stage are we in? What is the appropriate treatment for this stage, right? That's the one thing you need to look into. So now how you're going to answer this is the questions. How will you answer this question? This is the same system we are using across different questions, right? So same system across different questions. This is a one system we need to study. So first you're looking at the critical data, right? You're seeing what is the most important data the question is giving you. So it says 3 month duration, significant range of motion, loss and capsular pattern, external rotation is most limited, pain 6 out of 10. Empty and full. These finds indicate a freezing stage, increase in pain, active capsular inflammation. So that's a very early stage. Freezing, frozen and thawing stage, and that freezing is the first stage. So this is the pain 6 out of 10 is indicating a very inflammatory state. So you need to be know that this is an inflammatory stage, and that's what the whole picture is showing you. Now, step one, after critical data, you're applying time and sequencing rule. The question asks for initial intervention. What is the first thing you're going to do? So eliminate advanced stage treatments. If you know it's an inflammatory thing and it's an initial intervention, that is what wanted. From this options, you can eliminate advanced stages, right? Step two, you analyze each option. Option A, great for mobilization. Great for mobilization or stretching technique appropriate for frozen or thawing stages when pain is low and more primary problem is stiffness. In the freezing stage with active inflammation, pain 6 out of 10 aggressive mobilization will increase inflammation and pain. Too aggressive for current stage, you need to eliminate it. Option C, progressive resistance. We can test strength due to pain and range of motion limitations. Strengthening is premature when the patient can't achieve functional range of motion pain free. And if this violates the progression rule, so you need to eliminate it. Now, option D, contract relax to end range. This is an end range stretching in freezing stage to increase the capsular. This can increase the capsular inflammation if you do this on the freezing stages. So pain is still dominant. 6 out of 10, too aggressive. You need to eliminate it. Now you go into the option B, education and gender range of motion. This addresses the current stage, right? You need to see this is the best option we need to do at this stage. So you are going for that one. Now, correct answer is B. Match the intervention intensity stage. Freezing is equal to gentle. Frozen is equal to moderate. Thawing is aggressive. Stretching, right? So stretching need to be more appropriate based on the stages. Attempting frozen stage intervention in freezing stage is common NPTE distractor. So you need to know the intervention is at the right stage at the right time, so you will avoid getting that wrong, right? So the clinical pearl here is diabetes is a risk factor for the C capsulitis. Prevalence is 10 to 36%, is 2 to 5% general population. The NPT often include relevant comorbidities. You need to always know that. So if you have any doubt that whether this is a arthritic changes or a frozen shoulder, because sometimes the capsular pattern can be seen in severe arthritis also. So how will you know? That's what I told you. You need to look into the critical data that question is giving you. It says that you have a diabetes, the patient has a diabetes, so you know that the patient already have a chance of capsulitis, right? So that's what you are. Now we're going to the next one. So that is the shoulder instability. So shoulder instability exists on a continuum of five micro instability, subtle subluxation to a frank dislocation. Instability can be traumatic, unidirectional Vanguard lesion surgery, or atraumatic, multidirectional bilateral rehabilitation, inferior capsular shift. Clinical classification usually they're into traumatic, anterior instability, apprehension test is positive, relocation test is positive, history of dislocation, often Vanguard lesion on MRI can be seen. Then we have a traumatic multidirectional sulcus sign, which can be generalized ligamentous laxity and bilateral and no trauma history. Then we have posterior instability, pain with the forward flexion with internal rotation, jerk test, and less, which is usually less common. So posterior instability is the most less common one, right? Posterior instability, pain with the forward flexion, internal rotation, jerk test, and less common. A traumatic multidimensional sulcus sign, generalized ligamentous laxity, bilateral, no trauma history are another thing that you need to look into. Okay, so a traumatic multidirectional sulcus sign, generalized accessity, no trauma. It's usually, they have a sulcus sign. So sulcus sign is where you feel that a depression on the AC joint is something that you also need to look into, right? Okay. Now, posterior dislocation management. When someone has a posterior dislocation, what you need to do, right? First time, anterior dislocation. Sorry, not posterior. Post dislocation management. After dislocation, what you are doing to do the manage this dislocation. First time, anterior dislocation, immobilize in external rotation, reduce recurrence. Traditional internal rotation sling is given. So you usually hold it like that and immobilize it 3 to 4 weeks if less than 25-year-old, 1 to 2 weeks if more than 25-year-old. These then progress range of motion and strengthening. Recurrence rate inversely related to age at first location. So the one of the major factor is when did you get the first dislocation. That really matters. The first dislocation is something that you need to note into. The rehabilitation principle: acute post reduction, 0 to 3 evoke immobilization, position based on age and mechanism, pain control, gentle isometric. And on subacute, you're going for 3 to 6 week progressive active range of motion, avoid provocative positions. Rotator cuff strengthening and scapular stabilization is the one goal of this 3 to 6 weeks of program. And on strengthening phase 6 to 12, you are progressive resistance in stable position, dynamic stability, drills, and neuromuscular control. This is a very important thing. They will have a lot of issue with the neuromuscular control. The progressive resistance in stable position and dynamic stability drill is one thing that you need to look into. Now, return to activity 12 plus week. You're looking at sport specific trainings, plyometrics, and gradual return to full activity. Usually what happen is in the earlier phases, so most of them will have an apprehension at the abduction external rotation, that's apprehensive position. So in early phases, post dislocation, progressive range of motion conservatively to allow capsular healing. The NPT test your knowledge of position specific precaution. So in the early phases, you need to make sure you're not putting the patient into abduction and external rotation. Over the line, as the time goes on, after 6 weeks, you probably can reduce that, but not on the earlier phases. That's one thing you need to know. Now we are looking into a dislocation practical questions. Try to go through the question and see what answers you are choosing. So I know when I put that, you already know the B answer, but the thing is, I want you to take it as honestly as you can. Okay, so let's go through the question, see which one you will choose. A 19-year-old college baseball pitcher suffered his first anterior dislocation at 10 days ago. A 19-year-old, so before 25, right? During a game, mechanism is abduction, external rotation, and posterior force. This dislocation was reduced in the emergency department. MRI reveals a Bangard lesion. He has been wearing a sling in internal rotation and is referred to PT. Current range of motion, passive range of motion of 110 degree and 95-degree abduction and 90-degree external rotation at the side, all painful at end ranges. Strength testing deferred. His goal is to return to pitching. What is the most appropriate initial PT intervention that you are going to do at this for this client, right? So you can again begin gentle range of motion in all planes, avoid combined abduction external rotation, refer for immediate surgical consultation for Bangard repair before beginning the PT. Discontinue sling and begin aggressive range of motion exercise to prevent ADC capsulitis. Initiate rotator cuff strengthening with resistance band in neutral position. So the correct option here is to go for a surgical repair. Now why is that? If you see that where is MRI reveals a Bangard lesion. Now Bangard lesion is that means you have a tear on the labrum of the shoulder. That is something you need to address before you go for any range of motion. Otherwise the chances are you can tear it even more and make it more painful, right? So you need to make sure you're not making the situation like that. So this question tests your understanding when to refer surgical consultation and proceed with the conservative management. At age 19-year-old, high recurrence rate. Studies show 80 to 90% recurrence in athlete less than 20 years with the first traumatic dislocation. If you have a first traumatic before 20 years old, there's 19, 18, 80 to 90% of recurrent chance, that's almost sure. There's only 10% chance that you will get lucky, but the higher chance of you getting the reoccurrence of surgical, so you probably need a surgery in these cases, right? Activity level: college baseball player, pitcher, overhead athlete, high demand on shoulder stability. Pathology: you have a Bankart lesion confirmed on MRI. Return to pitching is the goal. Now that become more and more significant. Analysis: the patient has three major indicators of surgical management: young age, overhead athlete, structural pathology. The evidence is clear that conservative management in this population has a very high failure rate. So evidence is already says that conservative management in these groups, especially very young, and you have a Bankart lesion, there's a structural change, pathology, then you probably need a surgery. That, conservation is chances are failing. Option A, conservative PT. While this would be inappropriate for an older, lower demand patient or someone without structural pathology, it is not optimal here. Recurrence rate with conservative management in this demography is approaches 19%. Option B, this is the most appropriate surgical referral. Current evidence support early surgical stabilization for young active patient with a structural lesion who wish to return to overhead sports. PT can begin post-operatively. So once you're done with the surgery, maybe then you can do with the post-operative PT. But in these cases, better that you are going for a conservative, the surgical repair, because these are the cases where conservative PT usually fail. Option C, aggressive range of motion. This violates safety principle. At 10 days post reduction, at 10 days post reduction, the capsule is still healing. Aggressive range of motion will disrupt healing and increase instability risk. So this you need to eliminate immediately. Option D, too early. We are only 10 days post-injury and capsular healing is incomplete. Strength testing was deferred due to safety. Violates progression rule. You need to eliminate it. Now, correct answer is B. No other surgical indication. Young age, less than 25, right? Oh my God, man. So it says about 25, we are not young anymore. Because I'm 25, I'm feeling old, man. Okay, high demand athlete, structural pathology, desire to return to overhead sports. These patients should be referred for surgical consultation early, not after failed conservative management. So A25 is that age group that you make a decision for shoulder dislocation, right? So NPT tests your ability to recognize when PT alone is insufficient. Young athletes with traumatic instability, Bankart lesion, or surgical candidates. Older sedentary patient without structural lesion may do well conservatively, right? So that's the patients who will be good for conservative. One more time, we need to look into the types. There's traumatic anterior instability, right? With the trauma, you have an history of trauma and you are seeing apprehension test is positive, which is you pushing to the external rotation. Patient face shows apprehension, fear of dislocation, that's called apprehension. And then relocation test is positive, history of dislocation with Bankart lesion on MRI is a traumatic anterior instability. And then there's a traumatic, you have a sulcus sign, generalized ligament laxicity, and bilaterally. So if you have bilaterally and laxicity is really high and there's no history of trauma, they become a traumatic multi-directional instability. Then you have posterior instability where pain with the forward flexion and internal rotation, and jerk tests become positive. This is posterior instability. So this is one thing you need to look into. Traditional, so you keep it at external rotation, immobilizing external rotation, reduce recurrence, and traditional internal rotation. Sling 3 to 4 weeks for less than 25, 1 to 2 weeks for if someone is more than 25. If you have a 25-year-old who want to get back to sports and Bankart lesion is there, you probably need a surgical intervention before PT. And avoid abduction, external rotation, apprehension position in early phases, especially in the early phases. Don't, and on the earlier phases, you need to make sure this position and pain control is what you need to, and then on the next stages it becomes scapular stabilization, dynamic control, neuromuscular control become the concern over there, right? Okay, now we are done with the shoulder. Now we are going into elbow, wrist, and hand high yield questions. Okay, now we are getting into the elbow, wrist, and hand. The first one, the most common in the exam and in the clinical practice is lateral epicondylgia. Now, tennis elbow. Lateral epicondylgia is a tendinopathy, not tendinitis, affecting the common extensor origin, primarily the extensor carpi radialis brevis. So, ECRB is the usual inflammation. Is the one tendon that is involved. It's more of a tendinopathy, right? It's characterized by lateral elbow pain with the gripping and wrist extension activities. This pathology is degenerative, failed healing, rather than inflammatory. So that's one thing you need to know. So epicondylgia, lateral epicondylgia is not just an inflammation, it's a failed healing. So there's a degenerative things going on right there, right? So the point tenderness over lateral epicondyle, typical 5 mm distal and anterior, pain with resisted wrist extension and radial deviation, pain with the gripping activities like coffee cup handshake, positive Mills test, passive wrist flexion with elbow extended, normal elbow range of motion, neurological exam negative. So tendinopathy with tendinitis is something that you need to look into. So tendinopathy is a degenerative collagen change, failed healing, chronic, and tendinitis because more acute. Now, inflammation less than 2 weeks. Management differs. Tendinopathy needs loading, eccentric loading. Tendinopathy need loading, not rest and ice. NPT expect you to know the distinction. So it's a very important thing. A lot of time we confuse it with tendinitis with the tendinopathy. When you have a tendinopathy, you need more of an eccentric loading to fix that issue than just a tendinitis. Tendinitis need rest and ice. Now, if you look at the exercise evidence-based management, there is an activity modification. You need to reduce aggravating activities, modify gripping pattern, eccentric wrist extensor strengthening, Tyler protocol glow standard, manual therapy, right? Mobilization with the movement, soft tissue techniques can be given. Counterforce bracing may provide short-term symptom relief, corticosteroid injection, short-term benefit, but worse long-term outcome. VSPG, and surgery only after 6 to 12 months of failed conservative management. Surgery is last option in this case. So the primary thing that you need to know is eccentric loading is superior to concentric for tendinopathy. NPT will test whether you choose eccentric protocol over traditional strengthening or passive modalities is another concern that you need to look into. A 42-year-old recreational tennis player represents with right lateral elbow pain 6 out of 10 for 8 weeks. She reports difficulty gripping her tennis racket, carrying groceries. Examination reveals tenderness 5 mm lateral epicondyle to the lateral epicondyle, pain with resisted restriction, positive Mills test, full elbow active range of motion, neurological exam. She has tried rest ice and NSAIDs with the minimal improvement. What is the most appropriate initial intervention? So she tried rest ice and NSAID with the minimal improvement. That means they were trying tendonize it. Eccentric loading is not done. So this is a good thing that you can try, right? So the correct answer is B. You need ultrasound to lateral leg followed by sun rest from tennis. Recommended corticosteroid injection for pain relief before beginning exercise program. Aggressive massage myofascial release to the common extensor erosion. None of this is going to really solve this issue. Now, how will you answer? As I told you, you need to first look into the critical data. What is the question is actually saying? What is that indicating, right? 8-week duration, chronic, not acute inflammation, failed rest days, NSAIDs, passive strategies, ineffective strategies were already done, and recreational athlete. So apply evidence hierarchy. Which intervention has the strongest research support? Option A, ultrasound, ice, rest, passive modalities have poor evidence for tendinopathy, right? So giving just passive treatment is not going to help tendinopathy cases. You need more active. Rest to further decondition the tendon. Multiple systematic review ultrasound is no better than placebo for lateral epicondylgia. This is outdated care you need to eliminate. So ultrasound does not have a lot of evidence right now, so it's not something you need to give, right? Option B, eccentric strengthening activity module, Tyler protocol, eccentric wrist extensor loading, has level 1 evidence. Multiple RCT shows significant pain reduction and functional improvement. So what actually work in these cases is wrist extensor loading, right? You need to load them eccentrically to create an actual change to the patient. Now, this is considered as the best practice. Option C, corticosteroid injection. While injection provides short-term relief, systematic reviews show worse long-term outcomes in a 6 to 12 month compared to PT. So, or wait and see approach. NPTE wants you to know the injection are not first line for tendinopathy. This may use later if PT fails, but PT should be tried first. Option D. While soft tissue work may be unattractive, the word aggressive is a red flag here. Aggressive manual therapy to inflamed degenerative tissue can increase symptoms. Additionally, this doesn't address underlying need to load, strengthen the tension. Insufficient as standalone intervention. Right, so the correct one is eccentric load activity modification will be the right answer. It's the most evidence-based for a tendinopathy. Remember, this is not tendinitis. So in PT reward choosing active intervention, strong evidence, or passive modalities of injection, right? So when you see tendinopathy, something that is chronic, more than 6 weeks, think load it. When you see tendinitis, acute, less than 2 weeks, protect it. So this is a high yield distinction for NPT that you need to know. So what is take home? Tendinopathy is tendinitis. Tendinopathy, you need to load it. It will be more than 6 weeks, more chronic kind of thing. If it's acute very tendinitis, less than 2 weeks, you need to protect it. You need to put the ice. You need to bring down the inflammation down, and then slowly build up the work on it. Next, we are going to the wrist carpal tunnel syndrome, another very important topic that you need to know. Now we are talking about carpal tunnel syndrome, or CTS. CTS is the compression neuropathy of the median nerve within the carpal tunnel. It is the most common peripheral nerve entrapment. Symptoms include numbness, tingling in the median nerve distribution, night symptoms, and weakness of thenar muscle in advanced cases. So paresthesia in median nerve distribution is something that you see in this case. A symptom worse at night or with the prolonged wrist flexion and extension. Another thing is positive phalanx test or thenar sign at the wrist. Then you have thenar muscle weakness, atrophy in severe cases. 2-point discrimination more than 6 mm or decreased sensation to light touch is another thing that you need to look into. And also nerve conduction studies confirm these diagnoses. Right, so one thing that usually they always come up to is the 2-point discrimination more than 6 mm or decreased sensation to the light touch. Very important to understand this one, right? Paresthesia in the median nerve distribution, not little finger. That's the ulnar nerve. Positive phalanx test. Wrist deflection for 60-second and tenile sign at the wrist is another thing that you need to look into. Okay. Now median vs ulnar nerve distribution is another thing. Median nerve, thumb, index and middle radial half of the ring finger. Ulnar nerve, you have little finger, ulnar half of the ring. If symptoms include little finger, it's not CTS. It's considered ulnar nerve pathology or cervical radiculopathy. So if you have symptoms coming down to this part, there's something you need to look into different, right? If in the median nerve, in the medial half of the part, this part, then it's more on the median nerve, and here also on the lateral part it's the ulnar nerve. So conservative management, neutral wrist splinting, especially night splint, reduces pressure in the carpal tunnel. Activity modification to reduce repetitive wrist flexion extension, nerve gliding exercise, median nerve glide tensioners, ergonomic assessment and workplace modifications, carpal bone mobilization. Sometimes it may improve the tunnel space. If conservative management or all this management fails after 3 to 6 months, you might need a surgical referral in these cases, right? Let me put that one. So first, always you're looking into how will you know it's a median nerve, not an ulnar nerve. You need to see where's the distribution that's affected. If it's a little finger, you need to know in the small cervical radiculopathy issue or on the lateral part. That's what you need to look into. And 2-point discrimination of more than 6 mm or decreased sensation to light touch is something you need to do for clinical diagnosis. Nerve conduction study confirm the diagnosis. Thenar muscle weakness and atrophies in severe cases can be seen in positive phalanx test, right? Wrist flexion for 30-second tenor sign at the wrist. Usually this carpal tunnel syndrome get worse at night, and that's something you need to look into. So severe CTS thenar atrophy, constant numbness and failed conservative management through to 6-month recurrent surgical referral. Test your knowledge when conservative care is not sufficient. That is something you need to look into. So practical question, a 38-year-old pregnant woman, 38 gestation, present bilateral hand numbness and tingling for 6 weeks. One thing you need to know, when someone is going through the pregnancy, there's increase in the fluid retention in the person's body. Now that is causing a reason, right? Index, middle finger. She reports difficulty holding her phone, wakes 2 to 3 times nightly with the symptom. Examination revealed positive phalanx test bilaterally, less than 30 seconds. Positive tenors at rest, normal thenar strength, normal cervical range of motion, spurling, test negative. She works as a data entry specialist. So all of this is actually leading to that diagnosis. So the critical data is what you're looking at this page. Now, what is the most appropriate intervention? Refer to physician nerve conduction study and post-op surgical consultation. Fabricate bilateral neural wrist splint for night use and recommend activity modification. Cervical traction, cervical spine mobilization to address possible nerve compression. Recommended immediate leave from work to rest wrist until after delivery. So with the carpal tunnel syndrome, one of the highest CPG is, mark my word, highest CPG, clinical practical guideline for this issue is splinting at the night. This has the biggest evidence right now, right? So questions test appropriate conservative management recognition of pregnancy related carpal tunnel syndrome. Critical data, what you're looking is 32 week of pregnancy and bilateral CTS symptoms. So there, it's not just a mechanical, it's because of the increase in the fluid retention. Actually both sides you have a conversion. Normal thenar strength, so it does not indicate it. Severe CTS symptoms affecting function and sleep, and positive clinical test. So important contrast here, what you need to look is that carpal tunnel syndrome common in pregnancy in 20 to 50% of pregnant women. Due to fluid retention, increasing carpal tunnel pressure, it's often resolved after delivery. Pregnancy-related contraindication for surgery. Conservative management is strongly preferred. So first, step 1, analyze the options. Surgical referral CTS in pregnancy typically manage conservatively. Symptoms often resolve postpartum. Surgery during pregnancy is avoided unless there's a severe nerve damage. Surgery is premature, you need to eliminate it. Now option B, neural wrist splinting, especially at night, as first line conservative management. CTS it maintains optimal carpal tunnel volume, reduces pressure on median nerve, combined with activity modification at work. This addresses the problem conservatively. Safe during pregnancy is the most appropriate option you need to choose. Option C, Spurling test is negative. Cervical range of motion is normal. Symptoms follow the median nerve distribution. There is no clinical evidence for cervical radiculopathy here. So treating cervical spine will not be the right answer in this game. So you need to eliminate it. Option D, complete work cessation. Well, activity modification is appropriate. Complete work cessation is overly restrictive and is not evidence-based as first line management. Conservative measurements, splinting ergonomics should be tried for. Additionally, leaving work create financial and practical burden, which is too aggressive and not the right option, so you need to eliminate it. Correct answer is B. For pregnancy related carpal tunnel syndrome with a mild moderate symptom, conservative management, splinting, activity modification, nerve glide is first line. Symptoms typically improve postpartum. Surgery is reserved for severe cases unresponsive to conservative treatment. If conservative treatment is not working, surgery is given. But especially in this case, if pregnancy is there, usually it's a postpartum, it will get resolved by itself. So there's no need of surgery in this one. So pregnancy, diabetes, hyperthyroidism, rheumatic arthritis are common risk factors for CTS. What is the risk factor? If someone has an arthritis, someone has hypothyroidism, again fluid is retaining. And then rheumatic arthritis, pregnancy, diabetes, these are certain things that you need to know. There's a risk for carpal tunnel syndrome. NPT often embeds relevant comorbidities. Always note them and adjust your management accordingly, right? Okay, the another one, tenosynovitis. This is a very common one that you see on the thumb, especially with our use of the phone, right? The one of the test is this one. This is called positive Frankel's test hallmark finding in decovent tenosynovitis. So decovent tenosynovitis is inflammation, irritation of the tendon in the first dorsal compartment of the wrist, abductor pollicis longus and extensor pollicis brevis. Common in new mothers. Repetitive lifting and carrying the baby, workers performing repetitive thumb and wrist movements, they usually get this too. So pain over radial styloid worse with the thumb and wrist movement. This is a positive Franklin test. Swelling over the radial styloid, pain with resisted thumb extension and abduction, tenderness over the first dorsal compartment. These are the certain things that you see with these patients, right? So Frankelson test technique, the patient make the fist with the thumb inside, examiner ulnarly deviate the wrist, positive pain over radial styloid. This is the gold standard clinical test for decovent. Specificity is more than 98%, right? Okay, so how will you manage these cases? So thumb, spica, splint, brace, immobilize CMC and MCP joint. Activity modification include reduce repetitive thumb and wrist, modify lifting technique, ice and anti-inflammatory modalities in acute phase, gentle active range of motion stretching once acute inflammation settles, corticosteroid injection, high success rate 60 to 90% conceived measurement, fail. Surgery, first dorsal compartment release if injections fail, right? So decovent is especially common postpartum new mother's risk due to repetitive lifting and hormonal change. One thing you need to keep in mind, if a case is, the question is like that, there's a mother, especially postpartum, and she has pain in her thumb, is due to hormonal changes and the physical activities she's going through at this time. There's a high chance of decovent tenosynovitis. It will present context in recent pregnancy or in the context of pregnancy or child care, right? Now, a 32-year-old woman who gave birth 6 weeks ago present with the right radial wrist pain, 7 out of 10 when lifting her baby. She reports pain when opening jars and difficulty with diaper changes, examination reverse swelling of radial styloid, positive Franklin's test, pain with resisted thumb extension, normal wrist range of motion. She has been using ice over the counter pain medication with minimal relief. What is the most appropriate initial PT intervention? So here we already told that in this issues where carpal tunnel syndrome and decovent synovitis, we need to give with the support, proper lift. So the issue is here is the lifting mechanism is that causing that, right? So these things, other answers are not the right one. So the correct answer is option A. So aggressive stretching of APL and EBP to reduce tightness and rest movement, it's actually going to cause more pain because there will be inflammation. Recommended immediate cessation of breastfeeding to reduce hormonal influence. So that's not that's a dumb answer you can put. Initial strengthening exercise for thumb and wrist extensors is also not something you really want to do. Okay, so we are continuing with the cervical spine now. This is another high yield question and high yield content area that you need to look into if you are preparing for an NPTE, and not just the exam but for the clinical basis also, right? So cervical spine, one of the most common is the cervical radiculopathy. Cervical radiculopathy results from compression or irritation of the cervical nerve root. You already know this, but usually the most common nerve root that you should get involved is the C6 or C7. Causes include disc herniation, right? Foraminal stenosis, osteophyte formation. So there's 3 common causes for the compression of the cervical nerve root. Sometimes it can be the disc herniation, sometimes it can be foraminal stenosis, osteophyte formation. So key features include dermatomal pain, myotomal weakness, and reflex changes, right? So C5, pain to shoulder, weakness in deltoid biceps, diminished bicep reflex is usually seen with C5. C6, pain on lateral forearm and thumb, weakness in the bicep, wrist extensors, diminished brachioradialis reflex. C7, pain to middle finger, weakness in triceps, wrist flexors, finger extensors, and diminished triceps reflex is another thing. So this is very important area. Okay, so this is something we need to know because this is a very high yield region, I will say. Now how will you know if C5 is involved? You will see the deltoid abduction is weakness, right? Biceps reflex is diminished, then that usually says there is a C5 involvement. Now C6, how will you know? C6 will be on the lateral part of the forearm, so the thumb area region, wrist extensors, diminished brachioradialis reflex. So C6 is around this, so this is all dermatomal region. Then C7, it comes to the pain to the middle finger and weakness on the triceps and wrist flexors, finger extensor, diminished triceps reflex. So usually if you have a C7 involvement, that usually come with the triceps, reduced triceps reflex. C8, pain to medial forearm, ring, little finger, weakness in hand, intrinsic, no reflex changes. So that usually come to the little finger region, right? So C5, C6, C7, C8 is usually involved, most commonly involved is C6 or C7. C7 is triceps, C6 is the lateral thumb region of that brachioradialis, all that comes in. C5 deltoid is and biceps. C8 mostly on the little finger, and there won't be any reflex changes. So keep that in your mind. The cervical radiculopathy means there's a compression or rotation of the nerve. Now different things can compress that. It can be a foramen stenosis, right, on the where it exists on the foramina, it can get compressed, or there can be osteophyte changes, or there can be disc herniation. Now one of the special tests you need to know is Sperling's test. Alright, Sperling test is a high specificity test. Positive Sperling test, cervical extension, if C lateral rotation and compression produces arm symptoms specifically. So this is high specificity, okay, 80 to 95% for cervical radiculopathy. If negative, radiculopathy is less likely, right? So if someone is coming with radiculopathic pain, one of the tests to specify it, what you can do is the Sperling's test. So what you're doing is you're doing extension, right, and rotation, and then compression to same side. So that create a pain down, that means he have involvement on that side, right, or cervical radiculopathy. Now conservative management, how will you conservative manage this? One of the best treatment is mechanical traction, so decompression of the nerve root, cervical mobilization, avoid provocative position, postural correction, ergonomic modification, neural mobilization, radial ulnar nerve glides, strengthening deep neck flexors and scapula stabilizers, activity modification, avoid prolonged neck extension and rotation. So usually they go into forward neck posture, which is what you need to prevent. So the deep neck flexors need to get more activated, and that will help in a lot of the neck pain. So some of the red flags requiring immediate physician referral is progressive neurological deficit, myelopathic signs, hyperreflexia, Babinski positive, and gait distribution, bowel and bladder dysfunction, and severe unrelenting pain. So these are the certain things that you need to look into. If you see any red flags like this, you probably need to look more deeper, because it can be a higher level compression, and it's better you go for a physician referral, probably get an MRI and see the extent of the compression there. Okay. Now the clinical part is, if conservative treatment management fails after 6 to 12 weeks or progressive neurological deficit occur, refer for MRI or surgical consultation, then NPTE test your recognition of when conservative care is insufficient. Sometimes you need to know that certain treatment protocol fails, the conservative management fail, so it's better you go for a MRI or surgical consultation that need this kind of approach, right? Now We'll look into one question for this cervical radiculopathy. A 48-year-old office worker present with a 4-week history of arm pain radiating to thumb and index finger. So that is into this part, right? And he reported numbness in thumb, difficulty gripping, pain and neck pain with the prolonged computer examination revealed positive Sperling test on left, decreased sensation in thumb and on the left bicep. So C5 is involved. C6 is involved, diminished brachioradialis C6, and upper limb tension test, median nerve bias reproduce arm symptoms. Okay, so there's median nerve involvement is there. So usually that goes into the index and thumb, right? That is the median nerve is involved. So these are C5, C6, median nerve, and Sperling test is also so cervical radiculopathy, right? Sperling test is positive, which is highly sensitive to the so here asking which one is involved. So as we know, C6 because brachioradialis is something that is involved. C5 is usually shoulder abduction, which is not severely involved in this one, so it is C6. Okay, so if you know this content, it becomes, this is a direct question, actually it's an easy one, you'll be able to answer this one. So things you need to look into is what is the clinical sign saying, what is the special test is indicating, and the median nerve bias is there, right? So that you know, and wrist extensors and left biceps is also involved, diminished brachioradialis reflex on left, that is indicating of C6. Okay, so lateral arm, forearm, biceps, wrist extensors and diminished brachioradialis is showing what? C6. So that is why we have a C6 as answer here. I hope you got it. Now let's go for the detailed explanation. Our NPTE strike system is being used. So this is a classic nerve root identification question, right? Just you need to look into the critical data, right? Analyze the findings systematically. There's a sensory numbness in the thumb and index finger, motor weakness in biceps and wrist, which is a C6. Reflex diminished brachioradialis, so that's also 6 is pain distribution radiating to thumb and index finger. Now match finding to nerve root level. C5 affected the deltoid, shoulder pain diminished biceps, sensory to left, not thumb, right? So if you have a C5 region involvement, then usually it will be abduction will be reduced, your biceps is involved and the lateral part, right? So the lateral part of arm is involved, not to the thumb. Then C6 come down, it's, you know, the extensor, this is what is actually involved, your biceps, wrist, brachioradialis, diminished brachioradialis reflex, sensory to lateral forearm, thumb, index finger, perfect match to the all findings. So C7 affect triceps, wrist extensors, finger extensors, diminished triceps reflex, sensory to middle finger doesn't match, wrong answer, so that's going out. C8 F in hand, intrinsic sense insensitive to medial little fingers. So usually C8 is on this one. This is all dermatomal patterns which you know, right? So memorize the C6 vs C7 distinction is very important for this exam. There are two commonly tested in PTE. C6 is thumb, biceps, wrist extensors and brachioradialis reflex. Okay, C6 vs C7 is a very important thing you need to know. So C6 is your thumb, your biceps and your wrist extensors. So you can remember like this: your thumb, biceps and wrist extensors. Brachioradialis is also known, so that is this is a C6. Now C7 you have a middle finger, triceps and wrist flexors. This is the triceps extend, triceps, middle finger and wrist flexors. So this one. So think about this one as a C7 thing. Okay, your wrist is flexed and your triceps is going into extension. The reflex is getting that's C7. That's how I think that is that is C7, C6, 6, 7. So this is 6, C6. This is flexed and going like that. That is C7. So C7 triceps is getting that reflex. The wrist is more flexed, and middle finger is goes to the middle finger, right? So I hope you remember C6, C7, C6, C7. Do it with me so you will never forget. C6 vs C7. How will you remember it, right? Okay. Now this is another common condition called whiplash associated disorders, right? Now this is the very important thing you need to know, because patients comes to the clinics after a motor vehicle accident, or you fell anywhere, hit anywhere. It can create a lot of issues for these patients. So whiplash associated disorder result from sudden acceleration, the acceleration forces to the neck, typically from motor vehicle collision. It exists on a spectrum from mild neck pain, BAD1, to fracture dislocation, BAD4. Okay, so we have a classification for this whiplash, and it usually starts from mild neck pain 1 to fracture dislocation. So whiplash associated disorders: 2, neck pain with the musculoskeletal sign, and BAD3, neck pain with the neurological sign, are most common in PT practice. It's a very important thing you need to know. Sometimes you have a musculoskeletal pain signs, sometimes you have a neurological sign, so that will become BAD3. So you have a classification for that. That is a Quebec classification. So BAD0, no neck compliance, no physical signs. Someone had a whiplash, but there is no significant clinical signs, so that becomes BAD0. Now if someone comes to you with a neck pain, stiffness, or no physical signs, that is BAD1. Now BAD2 and 3, this is the most common what you see usually in the patients comes to you. You can get this group too, but usually it's BAD1 and 2. 2 is 2 and 3, sorry. So BAD2 is neck pain plus musculoskeletal sign, reduced range of motion, poor tenderness, and all the thing. BAD3, you have a neck pain plus neurological signs, so decreased deep tendon reflex, weakness, and sensory deficits are something you usually see. So that is BAD3, and BAD4 become fracture or dislocation. So this probably need a physician visit, and probably you need a fixation for that. But usually they won't directly come to the clinics, or there's something you should know. So BAD0, 1, 2, 3 and 4. 3 and 4 is what you usually get. 3 you have musculoskeletal sign, and 4 you have neurological signs like changes in reflex, weakness, and sensory deficit. So acute management is stay active. Evidence supports strong support for early mobilization, return to normal activities within pain tolerance, or prolonged rest or cervical collar use. Prolonged immobilization associated with the poor outcome and chronic pain. So one of the things that we see again and again, that someone who has a whiplash injury try to not move around, try to be very protective, that actually intensifies the chronic pain. So whiplash injury is a very interesting case, where what happens is, even after 20-25 years of whiplash injury, people still get a headache, people still get tightness, people still get pain in the neck. Now a large reason for that is that being overly protective about their injury, when you don't have a significant injury to your neck, right? Unless and until it's in a VAD5 with no fracture and dislocation, you should start mobilize in pain within the pain tolerance, right? That's what it is the evidence says. So evidence-based management acute for less than 3 weeks, you need to educate, reassurance, and encourage activity, change active range of motion, and active modification. Short-term color use only if necessary, less than 72 hours. That's what you need. Now you go to subacute progressive range of motion exercise, strengthening neck flexors, extensor, scapular stabilizers, manual therapy, and gradual return to work activities. Now then we have chronic, which is more than 12 weeks. So here we need a multimodal approach. including exercise, manual therapy, pain neuroscience education, and greater exposure to field activities. Very important concept of greater exposure to field activities. Now, clinical points. The NPT will test whether you choose early mobilization activity over prolonged rest. Evidence clearly shows stay active is better outcomes. A rest collar more than 72 hours worsen the outcome. So it's better always in this whiplash injuries that to move around in the pain tolerant range of motion than keeping them non-moving and resting. So you choose early mobilization activity over prolonged rest is what is that thing you need to know. Now, a 34-year-old woman presented to PT 48 hours after rear-end motor vehicle collision. So that's 48 hours after. Right, can be, we can still call this acute. So she reports neck pain 6 out of 10, headache and difficulty turning her head to check blind spot while driving. She has been wearing cervical collar continuously since accident. Examination revealed decreased cervical range of motion, tenderness out posterior cervical muscle, non-neurological deficit, normal reflex. She is very anxious about moving her neck and fears make it worse. She is classified BAD2. What's the most appropriate intervention? So that's a musculoskeletal, right? So that's BAD2. So what is the best way to do? Continue cervical collar. We already told it that's not what we want. Educate on being nature of BAD2, reassurance about safety of movement, gentle range of motion exercise, and collar discontinuation. Aggressive cervical mobilization might cause more pain. Complete rest all activities work until pain resolves, prevent chronic triple. This is also wrong. So the right answer is, as we already discussed, is the B. So if you're looking into a NPT strike system of clinical reasoning, this is the only way you want to know the system. Once you know the system, you can answer all the questions in this exam. It's going to be really easy. So NPT strike, you have one exam, one answer, and that's one course that you need. And this is we're giving it completely free for this musculoskeletal class because I wanted to help the students who go exactly through the doubts, the pain, the suffering that I went through, right? So let's see how we're going to use this NPT strike to answer this question. First, you need to look at the critical data. 48 hours post very acute, right? Post injury. VAD classifications, neck pain plus musculoskeletal side, non-neurological involvement, and they have been wearing collar continuously and high fear avoidance, so anxious about the movements. Now, step 1. You need to apply the evidence hierarchy. When an intervention comes in, you need to see which one has the highest CPG, so clinical practical guideline, which one has the highest evidence. So multiple systematic reviews and clinical practice guideline for VAD shows prolonged collar use more than 72 hours is associated with the worse outcome and delayed recovery. Early mobilization and return to activities associated with the better outcomes. Fear avoidance is a strong predictor of poor outcome and chronicity. Patient education and reassurance improves the outcome. So this is the getting that protein in, right? Okay. So actually, fear avoidance pattern is a poor prognosis in a lot of this chronic pain. We don't want them into chronic pain because once it goes into the chronic pain, it becomes really hard to break that cycle, break that loop, right? So step 2. So once you know which has highest evidence, you already know the highest evidence is not cervical collar or rest, but pain tolerant range of motion, right? Option A, a continuous collar for 2 weeks is directly contradicted best evidence. CPG VAD prolonged immobilization is the risk of chronic pain, muscle disconditioning and fear avoidance. This is outdated, care eliminate. Option B, education, reassurance and gentle range of motion and discontinue call. This addresses all the key evidence based intervention. Education about being prognosis of VAD2 reduces fear, reassurance about movement safety, addresses fear avoidance, active range of motion, and collar discontinuation. Prevent prolonged immobilization. This is best practice. So remember, this is not just for the exam but for your practice also. Okay, so very important. And a lot of the neck pain, a lot of the back pain, you can actually bring down the pain significantly down if you have this concept right. This is a holy grail of chronic pain, and if you get this one skilled, I don't know, man, you're going to be rich also. Not like that, but you know. Option C, aggressive mobilization. The word aggressive is always a red flag in acute injury. 48 hours, right? Manual therapy has a role in where the aggressive treatment in acute inflammatory phase can increase pain and fear. Additionally, the patient education and fear education must come first. Too aggressive for acute level, you need to eliminate it, right? Option D, complete rest. This is opposite of current evidence. Complete rest and work cessation promote fear avoidance, catastrophizing chronicity. So basically what happens is, if you give a little more than what you need, you are aggravating that fear pattern. Or if you keep it rest, you are telling the brain, oh, actually there is an injury, you need to rest, and you are aggravating or catastrophization of the pain is also made happening, right? So you don't want to so it's if I put like a story, a baby is walking, a child, not a baby won't walk, right? A child is afraid to go into a dark room, and the less you expose him into the dark room thinking that there is a danger, he's going to be more and more scared. But if you show him there's nothing in the dark room, he's going to be there, oh, so that's safe, right? So that's the whole idea of this one. Now, so the correct answer is the, change the color, that's not the right answer. Right, so correct B, for acute VAD the evidence is clear. Educated reassurance and encourage early movement and discontinue prolonged collar use. Address fear avoidance early is critical to prevent the chronicity. So fear avoidance and catastrophizing are strong predictor of poor outcome in VAD than injury severity. NPTE expects you to recognize and address psychosocial factor, not just biomechanical issues. Sometimes it's more than just a biomechanical issue that need to be addressed. If you made it till here, you're great, because I did it. I took 2-3 days to shoot this. If you see, I'm in a different location, different shot, Oh man, this is a long stretch. So, but the thing is, if you get a catch of this one, you're going to get a lot of mark, a lot of score in your NPTE exam, right? So now we are going into the thoracic and lumbar region now. We're talking about the lumbar disc herniation. So lumbar disc herniation occurs when nucleus pulposus material protrude through the annus fibrosus. Potential compression nerve root L4, L5, L5S1 level account for 95% of lumbar disc herniation. Think about that. L4, L5 and L5S1 is 95% of disc herniation. Symptoms range from lockless back pain to radiculopathy, depending on nerve root compression. Now, usually what happens is unilateral leg pain more than back pain, especially with the nerve root compression. Dermatome sensory changes, myotome weakness, or flex changes. Positive straight leg raise of some test, high sensitivity for lumbar disc herniation. Worse with sitting, forward bending, and Valsalva maneuver. Pain better with the standing, walking, lying with the knees bent. So if someone's pain is getting better when they are standing, walking, and lying with the knee bent, then usually that means it's disc herniated, because as I sit down, you're compressing it more. Like you have a forward bending, that is causing more pain. That is all indicating of a disc herniation, and usually it should go like sciatic pain, shoot down to one side of the leg, right? So L5 S1 radiculopathy as we read in C6, C7. What is C6? This one. C7, this one. Good job. Right, L5, dorsiflexion weakness, sensory to dorsal foot and great toe, no reflex changes. L5 become plantar flexion weakness, sensory to lateral foot, little toe, diminished Achilles reflex. These are two most commonly tested lumbar levels on NPT, so this is something you need to remember, right? I mean, you probably already know. So the L5 is S1 radiculopathy. How will you diagnose it, right? No, directional preference assessment. There is something called directional dependency. So McKenzie treatment method is one of the most effective in these cases when patient has a radiculopathic issue. You can really use McKenzie, but only thing, sometimes what happen is somehow this patient might have spondylolisthesis also. So these are the time when you need to be a little more cautious, because if you find there's a listhesis, you might need to be a little more cautious with that, right? So assess the patient response to repeated movements in extension, flexion, and side gliding. Centralization. Symptoms move from distal to proximal, indicate a good prognosis and guides treatment direction. So when you give the McKenzie method, what we are trying to do is we are actually trying to see if the symptom is moving from distal to proximal, and if it is happening, that is giving a good indication that the patient is actually getting better. Okay, so we are going into the movement based on presentation. So acute with radiculopathy, activity modification, position of symptom relief, McKenzie directional exercise if centralization occur, and neural mobilization when it seems appropriate, right? And subacute, improving, progressive strengthening core hip, gradual return to activities, and ergonomic modifications need to be done. In reflex, you need to look into squat equina syndrome like sudden anesthesia, bowel and bladder dysfunction, bilateral leg symptom, and progressive weakness. You need to go for an immediate referral. This is a very big thing you need to know. Okay, this is the quad equina syndrome, sudden anesthesia, bowel and bladder dysfunction, and bilateral leg weakness is something you need to be really cautious about, because these are symptoms where you have red flags, right? It's indicating that it's a compression of the quad equina that need to be addressed as soon as possible. Centralization phenomena. Symptoms move proximally with the repeated movement is a good predictor of outcome with the conservative care. Peripheralization, move distally suggests different approaches. If pain is shooting down more distally, then that means that movement pattern is not what we really need, right? So there's extension preference, centralized pain, centralized with repeated extension. You need to go extension based exercise. Flexion preference, pain centralized with the flexion based exercise, which is very less common. No direction may require different approach or more investigation is needed, right? So practice question: a 42-year-old construction worker, person with a 2-week history of right posterior thigh and lateral leg pain radiating to dorsum of the foot. He reports difficult walking on his heel and numbness over the dorsal foot. In grade 2, examination reveals posterior straight leg raise at 40 degrees on right and weakness of 3+ out of 5 in right ankle, dorsiflexion, diminished sensation to light touch on dorsal foot. Normal Achilles reflex bilaterally, normal knee reflex bilaterally. Repeated lumbar extension in standing causes symptom to centralize from foot to knee. Which nerve is more likely influenced? So you need to look is the straight leg raise is positive, so that's the radiculopathy sign. Alright, and he says dorsiflexion is N1, so that is more on the L5, right? S1 is plantar flexion. So if you know the dermatomal action of that nerve root, you can actually get, so on right weakness on dorsiflexion is indicating of a L5 involvement. So detailed. Step 1, systematically analyze clinical finding. Motor angle dorsiflexion weakness 3+ out of 5, sensory dorsal foot and grade 2 numbness, reflex is normal. Pain distribution, posterior thigh and lateral leg, dorsum of the foot. Special test positive, straight leg raise, centralization with extension, which is a good prognostic sign. Steps 2, march to the nerve root. Right, so the L3 affect the hip flexors, knee extensors, sensor to anterior thigh, diminished knee reflexes, which does not matching the findings. L4, it's more on the quadriceps and tibialis anterior. L5 is dorsiflexion, hip abductors, right, and S1 is on the plantar flexors, which is getting affected there. Right, so L5, S1 is more on the plantar flexion, and L5 is the right answer because your question is dorsiflexion, right? Let me take this one off. So the correct answer is C, L5. L5 radiculopathy, dorsiflexion, weakness of foot drop, and dorsal foot, great toe, sensory loss, normal reflex. L5 is the most common affected lumbar nerve root. Bonus clinical raising, centralization with extension suggest extension-based McKenzie exercise would be appropriate treatment, in addition to addressing nerve root compression symptoms. Memorize L5 is S1. These are tested repeatedly on NPTE. Okay, L5 is dorsiflexion, dorsal foot sensation or change on the reflex. S1 is the plantar flexion weakness, lateral foot sensation, and diminished Achilles. Now we are going into another condition in the back, lumbar spinal stenosis, very high impact region. Okay, so this is a common case that you usually see in the clinics, especially if you have someone who's have a lot of extension in your spine. Now, what do I mean by that? Someone who is running, someone who is really physically active is going to get this issue. Lumbar spinal stenosis is narrowing of the spinal canal or the intervertebral foramina, causing compression of the neural structures. It's typically degenerative aging related, affecting the older adults more than 16 years. So key features in neurogenic claudication, leg symptoms with walking, standing that improve with sitting flexion. Usually walking and standing improve with the sitting and flexion. So sitting is better for them, and flexion is which is opposite to disc herniation on the back. Okay, so especially the older adults above 16, there's degenerative changes. Key features in neurogenic claudication is there. So these are the things that you've seen with the lumbar spinal stenosis. Neurogenic claudication, bilateral leg heaviness, weakness with walking, is relieved by sitting flexion. Variable distance of symptom onset, symptoms improve slowly after rest. So vascular you need to know the difference between neurogenic claudication and vascular claudication. So vascular claudication, calf pain only with the walking, right? Consistent distance to symptom onset. So the more you walk, the more dull achy pain on your calf. Rapid relief with the standing still, pulses diminished, right? So if you walk, you're gonna get in more, but you stop and stand, the symptoms going to go down, right? So shopping cart sign is something that you usually seen with these patients on spinal stenosis. So what happens is patient with the spinal report less symptoms when leaning forward on the shopping cart. Lumbar flexion increases the canal diameter. So this is a pathognomic neurogenic claudication and help differentiate from vascular causes, right? Vascular causes is that is blood supply is very less going to the calf, so that is actually causing this deep aching pain because of the lack of the blood flow to the calf. Conservative management, flexion based exercise, lumbar flexion increases spinal canal, aerobic conditioning, stationary bike, aquatic therapy allows forward leaning posture, core stabilization in neutral or slightly flexed posture, or you can use the activity modification. Weight loss, if applicable, reduce mechanical lock, surgical decompression if progressive neurological deficit, severe functional limitation despite 6 month conservative care or Kodak-Koena syndrome. Right, so what happens is after certain times, if it's not being addressed for a long time and it's been progressing for a long time, so surgical decompression is something you need to look into if you are seeing a neurological deficit with a significant limitation. There's a functional limitation despite 3 to 6 months of conservative care or Kodak-Koena syndrome. So patient with the spinal stenosis do worse with the spinal extension exercise opposite to disc herniation. Always as directional preference to avoid exercise that increase symptom or cause peripheralization. So you need to see the directional preference of that patient and then try to give the exercise. Otherwise you might increases the pain for the patient, right? Now we're going to look into questions. Okay, so we are next going into hip and pelvis. Okay, so this is the last question of the lower lumbar region. So a 68-year-old man reported bilateral leg pain, heaviness when walking more than 2 to 3 blocks, relieved by sitting down for several minutes. He stated that symptoms are better when he leans on a shopping cart or walking uphill. Examination revealed normal lower extremity strength, normal sensation, normal reflex, normal perial pulse. Lumbar extension produced bilateral leg symptoms. Lumbar flexion release symptoms. MRI show moderate central canal stenosis at L3, L4, L5. It is the most appropriate. So anything that goes into more into flexion, lumbar flexion exercise and core stabilization, this is going to be the right answer. But you need to look into other one. Okay, high impact aerobic, aggressive lumbar manipulation, no. Lumbar extension, no. So jogging is good for aerobic, but aerobic issue is not going to fix the issue on the back. But actually, the jogging, running, jumping, these create a lot of extension to the back. So it's not the right answer. So if you high impact active upright posture, which is causing exertion, would worsen symptom. Additionally, neurogenic claudication limit walking tolerance, making jogging inappropriate for current activation level is something you should know. It's not the right answer, but something you should really know. Okay, so don't give any kind of high impact exercise to someone who comes to you with the stenosis. I might give a cycling. Okay, so extension exercise will make it worse. You know that. Understanding the pathomechanic lumbar extension decrease canal diameter worsen the stenosis, so that's not a good option. Now we have option B, core stabilization flex. This matches patient directional preference, symptoms improve with the flexion, is evidence based for spinal stenosis. That become the right answer. So these are very easy, direct. If you really know the content behind it, you can really come to this answer very easy. So the correct answer is B. For spinal stenosis with the flexion directional preference, prescribe flexion based exercise and activities that maintain increased canal diameter will be better, like a bicycle, aquatic therapy, and flexion stretches. So NPT love to test the spinal stenosis via disc herniation, and it is their directional preference. Stenosis is equal to flexion help, disc herniation extension help. Know the difference before you make a directional preference exercise. Oh my god, I'm really tired. I don't know guys, I don't know if you're really making it till here without taking a break, without stopping one day. That's really good, man. You're going to pass the exam today. And the NPT exam is that long duration endurance. That's what it's actually testing. If you're ability to sit for 5 hours and complete that exam, that's what it matters. So okay, now we are going into the hip and the pelvic. So one of the most common one that you usually came across is the femoroacetabular impingement, and this is one of the most common questions that can be asked on this NPTE exam also. So femoral acetabular impingement is abnormal contact between femoral head neck junction and acetabular vein, causing pain and damage to the labrum and cartilage. There's two type: CAM, femoral sided spherical femoral head, or we have a pincer acetabular sided excessive acetabular coverage. So there can be two things. The femur is big, right, femoral side, and that is causing a femoral head issue. The other one is acetabular side excessive acetabular coverage, and that is causing more of an issue. And it can be mixed, usually seen in athletic active adult who is very active into these activities, right? So usually when they get is an anterior hip and growing pain with the sitting, squatting, getting in and out of the car, and you have positive flexion, adduction, internal rotation, pathognomic positive fibrous stress may also be positive, but usually less specific. But flexion, adduction, internal rotation test will be really possible, right? Deep hip pain with the prolonged sitting is another one. Hip flexed more than 19 degree, going to create a lot of patient pain. C sign, patient makes C with the hand over anterior hip and growing when describing pain. Look, they want to say that here is the pain, like here is the pain, right? That is usually from this C sign, right? Then you have a decreased hip internal rotation in flexion. Flexion, adduction, internal rotation test is considered as the gold standard. Patient supine, hip flexed 19 degree, then passively adducted and internally rotated. Positive, go to the anterior hip, growing pain. High sensitivity and specificity for fibroacetabular impingement and labor pathology. So this is a gold standard. Okay, you need to know this test. Flexion, adduction, internal rotation test is something that you need to know about hip impingement. Hip impingement are two types: pincer impingement and you have CAM impingement. Okay, CAM impingement and pincer impingement. So femoral side is CAM, acetabular side is the pincer. Right, now we are going into a question there. So a 28-year-old recreational soccer player presented with the right anterior hip pain, 6 out of 10 pain for 6 months, whereas with the kicking, squatting and sitting for long periods. He reports a catching sensation in the hip. Examiner reveals positive Fourier test on right. Report is deep growing pain, decreased hip internal rotation, flexion 50 degree right to 35 left, hip strength 5 out of 5 in all planes. C positive sign. He completed 8 weeks of PT focus hip strengthening with the minimal movement. X-ray shows CAM morphology. What is the most appropriate next recommendation? So what are you going to do next? Now we need to consider this is a right hip, 6 out of 10 for 6 months. She is having for this pain for 6 months, and with anything that goes above 19 degree on the hip flexion is causing the pain. Catching sensation is the flexion, adduction, internal rotation is positive, so that's all going into the hip impingement. Decrease hip internal rotation, strength is good, C sign is positive, so right, and X-ray showed CAM impingement. Now what are you going to do the next? So continue progressive strengthening for next week, 8 weeks. But the thing is, here she already have a 5 hip strength, 5 in all planes. So hip strength might not be the reason that causing you that. Refer to surgical consultation for possible hip arthroscopy evaluation is another thing. Recommended complete cessation of soccer and transition low back is only might not work because it's been 6 months now having that pain, right? Trial of intra-articular corticosteroid injection followed by return to sport. And this thing is not an issue of inflammation, right? It's an inflammatory issue of an injury, pathological injury to the labrum. So that need to be addressed, otherwise they're going to have a lot of pain. Now, when you look at the critical data, young active athlete with a functional goal, return to soccer, positive flexion adduction, confirmed femoroacetabular impingement, structural pathology on X-ray, mechanical symptoms catching like labral pathology, failed 8 week of conservative PT is also there. So it has completed 8 week of focus PP, which is minimal improvement. That means he need to go to a surgery. So critical data is saying that this is structural femoroacetabular impingement, likely labral damage, and has failed appropriate conservative management. If they fail conservative management, they need to go to surgery. Now, option A, you can continue the PT. We already tried 8 week appropriate PT, it has strengthening with the minimal improvement. PT cannot fix structural bone morphology, cam lesion or repair or torn labrum. Continue the same approach, won't produce different result. This time more PT is always the answer, and you need to eliminate it. So in these conditions, very poor prognosis with the PT, to be honest. Whatever I've seen from the clinics, what I understood is that cam impingement and pincer impingement and labral tears need to address through surgical repair, because that is really annoying condition, right? So surgical consultation will be the right answer. So patient has 3 indications of surgical consultation: structural pathological morphology, likely labral tear, failed appropriate conservative management, and high function demand. Want to return to soccer, so arthroscopic surgery for FAI has good outcome in properly selected patient. This is the most appropriate final thing to do. Option C, permanent activity cessation. This is overly restrictive. While he may need to modify activities in the short term, permanent cessation of sports is premature when surgical option exists that could allow return to sports. So it's better go back to sports than not involving in sports and premature cessation of the sports, when you can go to sports after a surgery. So arthroscopic repair might be the better option. Option D, injection return to sports. Intraocular injection may provide temporary relief, symptom relief, but they don't under structural impingement or labral pathology. The relief should be short-lived, and returning to high-impact sports would continue the impingement cycle. This delays definitive treatment. So it's not a definitive treatment, it's just putting a tape on a wound, but the wound won't be healing. So you need to address that issue in a different way, and that is a laparoscopic repair. So the correct answer B, when femoroacetabular impingement with structural pathology, suspected labral tear, fails conservative management in young active patient, surgical consultation is appropriate. PT has limits, you need to recognize them. PT has limits, you need to recognize them, otherwise you will be really disappointed. So the NPT tests your professional competence in recognizing when to refer young athletes with the structural femoroacetabular impingement, labral tears, failed conservative care, or surgical candidates. So don't fall for more PT trap. Okay, I know we all want to be Superman, but sometimes it's better to not to be Superman. Important thing in life. Okay, remember that. Now we are going into the greater trochanteric pain syndrome, another very high impact thing you need to know. Now, tendonitis, tendinopathy is 2 things that you usually need to be addressed. So we have knee and patellofemoral pain syndrome, lateral ankle sprain, greater trochanteric pain syndrome, formerly trochanteric bursitis, is a lateral hip pain involving the gluteal tendon, primarily gluteus medius and minimus, or trochanteric bursa. Current suggests gluteal tendinopathy is more common than true bursitis. Risk factor include female sex, middle-aged, obesity, and active seasonal repetitive hip adduction. So if someone who's obese, someone who need to do the hip adduction a little more, is going to get a pain on the gluteus medius, on the lateral part of the thigh, usually from gluteal tendinopathy, okay, more than bursitis. Okay, so lateral hip pain, worse with the lying on the affected side, climbing stairs and prolonged standing, point tenderness or weighted trochanter, pain with the resisted hip abduction, positive tendon sign or gait, pain with the single stance on affected side, often associated with the excessive hip adduction during gait or stairs. So tendinopathy, recent evidence shows gluteal tendinopathy is the primary pathology in most cases, labeled trochanteric bursitis. Management implication: the lower the tendon, progressive strengthening, do not just reduce inflammation. So this is something a lot of people do wrong. When you have a tendinopathy, you need to eccentrically load it, right? Just thinking about bringing the inflammation down is not going to work. You will be in a constant cycle of inflammation if you are in that thought process. You need to constantly eccentrically load it. Okay, so activity modification: avoid prolonged hip adduction, cross leg lying on affected side, progressive hip abductor strengthening, gluteus medius, isometric, isotonic and functional. Address biomechanical factors: excessive hip adduction during gait, Tendlenberg pattern. Manual therapy: need to do the IT band release, hip mobilization as an urgent. Avoid compressive positions, don't sit cross leg, use pillow between the knees, then sideline. Now, people use corticosteroid injection, but the thing is, it's a very high short-term benefit, but recurrence is very, very high. So exercise therapy is better actually than corticosteroid injection. So avoid stretching in position that compress the gluteal tendon. So a lot of time you think stretching is going to help them, but the gluteal tendon should not be stretched. That going to create a lot of pain. So these compressive load can worsen tendinopathy. Focus on strengthening instead. So instead of stretching or releasing, it's better you compressive load the tendon. That will have better results. Now we're going to see questions regarding that. A 55-year-old woman presented with right lateral hip pain, 7 out of 10 for 3 months, worse when climbing stairs and lying on her right side at night. She is unable to sleep comfortably. Examination reveals point tenderness or greater trochanter, pain 6 out of 10 with resisted hip abduction, positive Tendlenberg sign on right hip, abductor strength 3 plus on 5 and right, 5 out of 5 on left, excessive hip adduction during single leg stance right. She has tried ice, non-steroidal anti-inflammatory with the minimal relief. What is the most appropriate initial intervention? We already saw that aggressive stretching is not something you want to do. Corticosteroid injection, it will give some relief, but that's not a permanent fix. Complete rest from is not something you want to do. So isometric hip adductor strength in neutral position and educate on avoiding compressive position is something you can do for this patients, because strengthening is something that you should be giving for tendinopathy. No, this is not tendonitis, it's tendinopathy. We are using the NPTE system, NPTE strike system. So we are looking at the critical data. What is the critical data? Says lateral hip pain, especially with the loading. We have pain and compression lying on side. Positive findings for gluteal tendinopathy, pain with resisted abduction, Tendlenberg signs, weakness 3 plus 5, excessive hip adduction, and failed passive strategies like ice and MSIDs. So recognize this is gluteal tendinopathy, not just bursitis. Pain with resisted abduction plus weakness plus Tendlenberg tendinopathy needs loading, progressive strengthening, not just inflammation reduction. It's very important, right? Option A, IT bend, stretch, sideline position, compresses gluteal region. Trochanteric burst against greater trochanteric excited mechanism that's aggravating, so I don't want that. Should be injections. While injection may provide short-term relief, systematic review shows exercise therapy progressive strengthening has better long-term and low recurrence rate than just bringing the inflammation down with the corticosteroid injection. Option C is the right one. Address both component. Load the tendon appropriate isometric strengthening, safe initial loading for tendinopathy. Address weakness and tendon bring a pattern educate on avoiding compression position, and that will help with the patient. Okay, so option D, complete rest. Rest deconditions the tendon further and doesn't address underlying weakness. Tendinopathy needs loading, progressive, not rest. Additionally, complete activity cessation is only restrictive, so it's violate the evidence. Evidence-based practice is the cornerstone, and we need to make sure we are giving that. Okay, so NPT is shifting from trochanteric bursitis to greater trochanter, tendinopathies with recognition of gluteal tendinopathy. When you see lateral hip pain plus weakness and tendinopathy, think tendinopathy and choose progressive loading over rest or passive modality. Is a very important concept. Anything with the tendinopathy, you need to load it progressively. Okay, so we are continuing with the anterior cruciate ligament injury. It's part 6. We are going to look into the knee. So the ACL injuries are common in athletes involved cutting, pivoting, and jumping sports. This mechanism is usually non-contact deacceleration with the valgus collapse and internal rotation. And so ACL provide primary restraint to anterior tibial translation and rotational stability, and usually the issues comes in when there is a issue with anterior translation and rotation, right? So the acute mechanism, what you hear is that you hear a pop or tearing sensation. There may be immediate swelling and giving away if you get a ACL injury. So usually what happens is your knee goes into more interior, and there will be internal rotation of the knee. And usually the test we will do for ACL injuries are positive Lachman test, right? So the anterior drovers test is similar, but the degree is different for Lachman. The degree where you keep your knee is different for Lachman compared to the anterior drovers test. Other tests you can do is positive pivot shift test, which is more specific and indicate rotational instability. The other one is difficulty with the cutting and pivoting activities, episode of giving away. Associated injuries are also common. If you get a ACL injury, usually it is a meniscus. Bro, just what?
I just want to get some.
Get it.
I feel like an meteor or something.
Oh no. Other associated injuries are meniscus injury, 15% chances of getting a meniscus injury if you get an ACL injury, and along with that you might get an MCL injury, which is 30% of chances with the ACL injury, and sometimes you can get a bone bruise also. The other one is what we need to know is difference between Lachman and anterior drovers test. So this is usually a common question that we can expect. So the Lachman test usually we do at 20 to 30 degree of flexion, which is more sensitive than anterior drovers test. So anterior drovers test we keep knee at 19 degree of flexion, right? But on the Lachman test is only 20 to 30 degree, which is more sensitive, and you're trying to see if there is an increased anterior translation of the tibia. Okay, and why we need to know, we also need to know why Lachman test is more sensitive than any DOS test. Usually because the hamstring are more relaxed on a Lachman test, so it can guard it, right? So sometimes what happen is, if you get an injury, the muscles try to guard it and protect it. So at 19 degree the hamstring is more active and it will try to guard it. So Lachman test is more sensitive in that sense. Now Lachman is a gold standard clinical test for ACL integrity. Alright, so gonna keep that as right. Now we have two type of management. One is the surgical management and conservative management for ACL. Now surgical indication involve young active patients, high level athletes, rotational stability, desire to return to cutting and pivoting sports. Then you probably need to give them a surgical indication, right? So they want to get back to sports, it's better to go for surgery than a conservative treatment. Now, when will you think about conservative treatment in this ACL injury? It's usually when they are older and you have a lot of demands on the patient, right? They are willing to modify their activities, and if you see a partial tear with a minimal instability, it's better to go for a conservative treatment, or you have a medical contraindication to surgery, someone who's hemodynamically not stable, or there's other issues going on. It's better to not go for a ACL surgery and instead go for a conservative treatment. Now one thing also is coppers with non-coppers. So what happens is some patient can return to activity without surgery through neuromuscular training, other persistent instability despite rehab. So no coppers, they might require surgery. So you need to know who will be able to get back to their games or their activity without a surgery, and with who will be better candidate for surgery. Now if someone need to go for surgery, it's a complete program will be 6 months plus, so 6 to 9 plus months. That's time to take to get back to playing the sports as they used to do. Now phase 1, which is a 0 to 2 weeks, the goal should be reduce swelling, restore range of motion, quad sets and SLRs, and weight bearing is tolerated with the crutches will be the goal. Now phase 2 is 2 to 6 week. Here we need to try to get full range of motion, and always we try to get the extension first and then flexion, right? So full range of motion normalized gait, progressive strengthening, close chain emphasis, and proprioception. Now we are going into phase 3, which will be 6 to 12. Here we are looking for advanced strengthening, running progression, agility drills, and straight line only at this 6 to 12 week of time. Now we are entering the phase 4, which is 3 to 6 months. Here we are looking at sport specific training, plyometrics, cutting, pivoting, progressions. Now full knee extension is critical, right? So post ACL reconstruction, there is an extension lag of more than 5 degree at 6 weeks associated with the poor outcome. So you need to make sure by 6 week you should be able to do full knee extension. So this is one of the indicating factor of that patient's clinical outcome, right? Prioritize extension range of motion or flexion in early phase is one of the most important concept we need to know in the ACL rehab. We're going to look into a question here. A 17-year-old high school soccer player is a 3-week post ACL reconstruction. So we did a hamstring autograft. She presented to PT with the knee range of motion 5 to 110 degrees. So there's lacking 5 degree extension and 130 degree of flexion. There's minimal swelling, 4 out of 5 quad strength, and antalgic gait. She's anxious to progress quickly to return to soccer. What is the most appropriate initial for this visit? So you need to look at the 3-week post ACL. At this time, swelling is coming down, and there is a 4 plus 5 quad strength. So
and she's anxious about getting back to the game. What will be the initial focus in this phase, right? Should we go aggressive close strengthening exercise to improve quad strength, knee extension range of motion exercise, prone hangs, heel props to achieve full extension, or begin jogging progression to prepare for return to running, or advanced proprioception exercises include single leg balance on unstable surface. Now, as we already told here, as phase 2 from 2 to 6 is the full range of motion. The most important range you need to achieve here is the extension. So that will be the right answer, the B. So if you look the NPT strike, way to answer this question, you need to understand the critical data first. So there's a 3-week post-op early phase, and then you have understand the range of motion deficit, lack 5-degree extension but has adequate flexion, quad strength 4 out of 5, and antalgic leg likely due to range of motion and strength deficit. So step 1 here we need to do is you need to apply progression rule, right? So at 3-week post ACL reconstruction, we need to understand what are the priorities. So evidence-based priority list, first we need to make sure achieve full knee extension, which need to be addressed. Then you need to reduce the swelling, you need to normalize the gait, quad strength and progression to range of motion in flexion, which is less critical than extension, right? Step 2, analyze the extension deficit. 5-degree extension lag at 3 weeks is significant and need immediate attention. Extension deficit lead to abnormal gait mechanism, poor cord activation, patellofemoral pain, and poor long-term outcome. This must be addressed first. So a lot of this patient, if they come back with a patellofemoral pain syndrome and poor cord activation, that is usually because of this extension lag. Now you need to make sure this extension lag is addressed as the highest priority, especially 3 week. First 2 weeks you should get that range of motion, but for this patient he is not able to get it, so that will be the highest priority. So that's the initial thing you need to do. Now you need to analyze options. Option A, you need to look in the aggressive strengthening. While quad strength is important, the word aggressive is inappropriate for 3-week post-op embroidery. You cannot effectively strengthen in the quads when there is an extension deficit. Quads work optimally in full extension. So attempting progressive strengthening before achieving full extension violate progression principle. So you need to stop that. So you need to understand the joint range of motion is what you really need. So it's not because of the quad is weak. Quad's already have 4 out of 5 strength right now. But how will you address this extension lag? So if you see here, you can give prone hangs, you can give heel props kind of exercise to get that range of motion back. Jogging progression, right now it's too early. You need to wait at least 8 to 12 weeks after achieving full range of motion and normal gait and adequate strength to progression to jogging progression. Now, advanced proprioception on unstable surface. While proprioception is important, advanced exercise on unstable surface at 3 weeks is premature. Patient can even walk normally, so at this time we don't want to go for new proprioception. So the final verdict, the right answer will be B. So achieving full knee extension, the critical priority in early post-ACL reconstruction rehab. Extension lead to cascade of problems. Always address extension before advancing to strengthening or functional activity. So NPT will test whether you know the correct rehabilitation and progression post-ACL reconstruction, right? So full extension by 2 weeks, full flexion by 4 to 6 weeks, normal gait by 4 to 6 weeks, jogging by 8 to 12 weeks, return to sports by 6 to 9 months is the usual progression of ACL injuries. Okay, now we are going to look into the patellofemoral pain syndrome. It's another common condition that can come up on the exam, and not just on the exam, as I always say. in a clinical scenario also. Patellofemoral pain syndrome is anterior or retropatellar knee pain aggravated by activities that load the patellofemoral joint. So especially squats, stairs, prolonged sitting and running, these things can cause pain in your patellofemoral joint region, right? So it is the most common cause of knee pain in active individuals. Someone who is really active, if they're getting pain on the knee, they're usually because of this patellofemoral pain syndrome. Now, there's multifactorial etiology, including biomechanical factors. Sorry about that. Biomechanical factors and muscle imbalance and training errors that is usually causing this. Now, what is the usual clinical presentation? The anterior retropatellar knee pain often, can come on bilateral side. Pain worse with the squatting, stairs, especially descending, and prolonged sitting. This is called theater sign. Crepitus with knee flexion and extension. Sometimes is present, sometimes is not. Positive patellar grind, compression, grind test, positive patellar grind test. So your compression with active quad contraction. You compress the patella when you ask the patient to straighten the knee. That's a patellar grind test. Common impairment, they usually have weak hip abductors, external rotators, tight IT band bilateral retinaculum, lateral retinaculum, and excessive foot pronation is usually what happens, right? Poor VMO activation is also sometimes causing this issue. So if you address these things, the issue with the patellar grinding or the patellofemoral pain syndrome can be brought out. So strong evidence show that hip strengthening, the gluteus medius and external rotators, is effective or more effective than isolated knee strengthening for patellofemoral pain syndrome. So usually what happens is studies have shown that weak hip abduction and internal rotation, which is increasing the Q angle, right? Lateral patellar tracking can cause and treat proximal causes. So in these conditions where you have an issue with the VMO or the knee issues, it's better you go for a activation of the proximal muscles, right? So usually what we need is a hip abduction and external rotation training is needed more than internal rotation, because adduction and internal rotation, what happens is usually with that you will create the Q angle a little more higher, and which is creating some issues there in the knee. Now, there's an evidence-based management for patellofemoral pain syndrome is hip strengthening, glute medius maximus and deep external rotators as level 1 evidence, right? Knee strengthening, quads, especially VMO, close chain emphasis need to be done. Activity modification, reduce or modify aggravating activities temporarily, like patellar taping, McConnell taping for short-term symptom relief during exercise. You can also give foot orthotics if excessive foot pronation is present. You need to retrain the gait, running retraining, which reduces the override, increases cadence, and address hip drop is also need to be addressed, right? Now we have manual therapy, right? We have IT band, lateral retinaculum release, and patellar mobilization is usually what done, right? So IT band release, lateral retinaculum release, and patellar mobilization as an adjunct, so mobilization need to be done. So we call this terrible triad. So of patellofemoral pain syndrome is that weak hip, weak quads, and tight IT band, and the lateral structures. We call this terrible triad. So weak abductors, weak hip muscles, usually the glute medius and the external rotators, and then we have weak quads, and then if there's a tight IT band and lateral retinaculum, that can be a reason. So address all three for optimal outcomes. Hip strengthening alone often insufficient. It's a multimodal condition require comprehensive approach in these cases, right? We are going to look into a question here for patellofemoral pain syndrome. A 24-year-old recreational runner present with bilateral anterior knee pain for 8 weeks, worse with running downhill and after sitting for long periods at work. She has reduced her running mileage by 50% even with minimal improvement. Examination revealed positive patellar grind test. Bilateral hip abductor strength is 3 plus out of 5. Bilateral quad strength 4 out of 5. Bilateral positive obverse test. Tight IT band excessive hip abduction during single leg squat. What is the most appropriate initial PT intervention in this case? So what you really need to look into here is that what is the most appropriate initial PT intervention in this case, right? There is an answer says complete rest of running for 3 to 8 weeks, symptom relief, aggressive IT band stretching, foam rolling to reduce lateral parallel tracking, combined hip strengthening, glute medius and quadricep strength with activity modification. And you also can give parallel mobilization soft tissue early. Avoiding strengthening due to pain is not the right answer. So as you already know by what we're reading in the top, you need to know hip strengthening, glute medius focus and quadricep strengthening with activity modification will have better improvement in this patient's outcome, right? So you need to go with detailed examination there. You need to always use the NPTE strike method of answering this question. So first you need to look at the question, what are the critical data that this question is giving you, right? So first one is bilateral patellofemoral pain syndrome. So that's the classical presentation you have on both sides. So that usually comes with what increased activity, and there's a biomechanical disadvantage there. So you have bilateral, and then we see there's a weak hip abductors, there's significant weak quad strength, tight IT band, excessive hip adduction during the squat, failed activity modification, right? So these are the things that we need to look into. So step 1, apply evidence hierarchy. What intervention has level 1 evidence? Systematic reviews and RCT. So right now, based on evidence, high level 1 evidence, there's hip strengthening, strong evidence for this patellofemoral pain syndrome. Multiple RCTs and systematic reviews is actually supporting it. Then you have knee and quad strengthening, strong evidence, multiple RCTs are supporting it. You have combined hip and knee strengthening, that also strongest evidence, they're superior to either alone, right? Activity modification, you need to have a modification that's for some time to at least bring the pain down for some time, and then you can get back to the right way of doing it. Patellar shaping, short-term relief, not a primary treatment. IT band stretching manual weak evidence, but maybe an urgent but not a primary call there, right? So option A, questions, analyzing the option there. Option A, complete rest from running. You don't want people to take complete rest, right? Complete cessation for 6 to 8 weeks. Someone who want to get back to running. So rather than complete rest, you need to do modification of the activity will be better here, right? And option B, this IT band stretching and foam rolling, which has a very low evidence, right, actually. So stretching and foam rolling is not a reported as a primary treatment for patellofemoral pain syndrome. So that's the hospital evidence there. You always need to look at level 1 evidence. Option C, combined hip and strengthening knee as activity modification, that has the best practice and matches. There's a lot of RCTs and systematic reviews supporting that. So that need to be, what you should, the focus should be. Now option D, you have manual therapy only, so you need to avoid stretching. So there we are only giving manual therapy, it's avoided strengthening, so that's not actually helping you either, right? So you need to make sure these things are looked into. Okay, so correct answer is option C, and you need to look into the best outcome there. So the NPT expect you to know the current evidence for patellofemoral pain syndrome, right? Hip strengthening is as important as knee strengthening. Don't fall for the trap of treating only the knee while ignoring the hip. Now we are going into another interesting part, is the ankle and foot. Okay, so we are going to look into the plantar fasciitis, another questions that usually show up on the NPTE. Now, with the plantar fasciitis, this is one of the most common cases that comes up in the clinics also, right? So plantar fasciitis is the most common cause of plantar heel pain, affecting plantar fascia insertion at the medial calcaneal tubercle. Despite the itis suffix, histology show the degenerative changes rather than acute inflammation is seen in plantar fascia. So risk factor include you're obese, this prolonged standing, and then you have a pes planus, or sudden increase in activity. So these are the certain things that cause these issues in plantar fasciitis. So itis is inflammation, but most of the time it's a degeneration because of the constant stress that plantar fascia is going under. Now, plantar heel pain worst with the first step in the morning after prolonged sitting is called post-static dyskinesia. Now, pain improves with initial walking but may worsen with the prolonged weight bearing. Tenderness at the medial calcaneal tubercle, then the plantar fascial insertion. You have pain with the passive dorsiflexion of the toe, which is called windlass test. So that stretches the plantar fascia is one of the things you need to always keep in mind. Windlass test positive, plantar fasciitis, right? Often associated with the limited angle dorsiflexion or tight gastrocnemius. So if you have plantar fasciitis, there's two different things that you need to look into. Either obese, you have weight, increasing weight there, your food is going into more flat food, and then you have this windlass test might be positive, and there's reduced dorsiflexion for these patients, right? First step, pain pathognomic, severe heel pain with the first step in the morning that improves with the walking is a hallmark of plantar fasciitis. This is a high yield for diagnosing on NPT. So if someone says that early morning when I take the first few steps, that's where I have a lot of the pain, that is usually showing that they have some issues with the plantar fascia, right? So evidence-based management say the plantar fascia specific stretching, standing calf with the toe dorsiflexion. So that's usually has a strongest evidence. So the plantar fascia specific stretching usually reduces this issue. So you need to stand and do a calf stretch, but you need to make sure the toe is in a dorsiflexed position, right? Now you have calf stretch, you can do the gastrocnemius and soleus, address common contributing factors. You have manual therapy, right? Plantar fascia mobilization, calf, foot, or soft tissue work, and then you have foot orthosis of or arch support that need to be there. Also night splints, so maintain the dorsiflexion overnight for recalcitrate the cases, right? You need to have sometimes activity modification, reduce high impact activities temporarily. You can go the corticosteroid injections, short term relief, but the risk of fascia rupture and fat part atrophies is there. So use cautiously when you give a corticosteroid injection. Now, extracorporeal shock wave therapy for chronic cases, especially with that goes above 6 months, failing conservative treatment, you can do that. So clinical pro, what you need to really keep your in your heart is that plantar fascia is typically self-limiting, resolved within 12 to 18 months, but can be very disabling. The pain can limit the patient. Most patients respond to conservative management within 6 to 12 months. So surgery is rarely needed in these cases. So look at your case. This 45-year-old postal worker person with right plantar heel pain, 7 out of 10 for 6 months. Worst with steps in the morning, Pain improves after walking 10 to 15 minutes, but worse by end of the workday. After prolonged standing, she has tried over-the-counter arch support and ice with minimal relief. Examination reveals pointer numbness at the medial calcaneal tubercle, limited angle dorsiflexion, and tight gastrocnemius. Positive wellness test, BMI is 32. What's the most appropriate initial PT intervention? So what is the best intervention here? So plantar fascia and calf stretching program combined with activity modification and footwear assessment is the best option here, right? So aggressive deep tissue massage is usually not something we need to do. Recommended corticosteroid injection, it's there, but it's only when all conservative management is failed, and then you can give corticosteroid injection, but it has a risk of rupture. And recommended immediate cessation of work to allow complete rest and healing is not a good way to do. So the best answer will be plantar fascia and calf stretching program will have a lot of effect on these cases, right? Level 1 evidence, plantar fascia specific stretching, which has a strong evidence. So calf stretching, activity modification, foot orthosis, moderate evidence, manual therapy, weak to moderate evidence, injection has short-term benefit versus long-term versus short-term benefit versus long-term, right? The strongest evidence is the issue with the dorsiflexion limitation. Okay, calf stretching, especially with the limited dorsiflexion, is one of the things you need to look into. A lot of the time, the patients who comes with any kind of ankle issue, even knee issues, right, the dorsiflexion is even limited, and that is causing a lot of issue there. So you need to make sure the dorsiflexion issues is addressed. Without that, there can be a lot of other compensatory issues coming up. So the correct answer is B. First line management of plantar fascia is plantar fascia specific stretching, calf stretching, and activity modification. This is the strongest evidence compared to all other options there. You don't want to complete rest, right, which will create financial hardship for the patient, and plantar fascia require load management, not complete avoidance. So that's not the right answer. The stretching program was activity modification, footwear assist. This is comprehensive first line care, right? Plantar fascia stretching as level 1 evidence, calf stretching is limited dorsiflexion. So that is the right answer. Everything that you need to do is in there. Aggressive deep tissue massage, usually inflammation, increase inflammation and pain, especially in chronic degenerative tissue. Management should be gentle, not aggressive, used as an adjunct of stretching. So that need to be keep in mind, right? Injection before exercise has short-term benefit, less than 4 weeks, but systematic review shows worse outcome long-term compared to exercise therapy. So there can be recalcitrant, and sometimes it can go to fat part atrophy. Sometimes it can even lead to tear of the plantar fascia. So corticosteroid is a short-term pain reliever, but not a complete fix there. So NPTs love plantar fasciitis question. Remember, stretching is first line with the strongest evidence. Injection is not first line. They provide short-term relief, but worse on long-term PT outcome. Okay, so we are officially completed that different body part musculoskeletal masterclass joint by joint. We covered a lot of topics in this. This is going to be a long video, but this is an NPT mastery and completely going through different high yield topics that you need to know. We in our course, in a complete course, we're going to go even more deeper. Every single joint, every single case that you need to master in musculoskeletal in the big 3 course will be there. This is a completely free masterclass for you, but if this helped, consider subscribing so we can upload more videos for you, right? And next, our goal is to create a video all special tests that you need to know for NPTE and that will be uploaded. That will be in this YouTube channel, completely free for you. All the special tests you need to know for NPTE, clearing this for the first time. So one course for this one exam, and there's only one answer, and that one course that you need to clear this one exam is NPTE Strike, and that's completely free for you, right? Take care, see you in the next video. Keep grinding guys. So we completed all this: rotator cuff, adhesive capsulitis, shoulder instability, lateral epicondyle, GA carpal tunnel, decomventinous synovitis, cervical radiculopathy, whiplash disorder, disc herniation, spinal stenosis, femoroacetabular impingement, greater trochanteric pain syndrome, ACL injury, patellofemoral pain syndrome, ankle sprain, and plantar fasciitis.